Good morning, good afternoon, and good evening to you all, wherever you may be in the world. My name is Luyanda Machija, and I am your moderator for today's webinar, which aims to explore how policymakers can advance access to screening for chronic kidney disease. In the series of discussions that we have at today's webinar, we are going to unpack the contents of a recently published policy brief, which I'm very excited about, called Screening for Chronic Kidney Disease, Addressing the Gathering Global Storm. This webinar is brought to you by the Global Patient Alliance for Kidney Health, which is a collective of national kidney patient groups from all around the world. They are patient groups which envisage healthcare systems that treat chronic kidney disease as a public health priority. Also referred to as GloPAKH, the Alliance is committed to ensuring that at-risk patients have adequate access to comprehensive screening and early treatment, which we know can slow disease progression and prevent mortality. An overview of today's session, we are going to get a fantastic outline of the various screening strategies and recommendations outlined in the policy brief. This will be followed by a panel discussion to take a deeper dive into the topic and glean the perspectives of a patient advocate and a clinician on CKD unmet needs in various contexts and the role of screening to improve kidney health outcomes. We would love to hear from you as always, so please use the Q&A box to share any questions, comments, or contributions you may have for our speakers, myself, throughout the session. We will do our very best to monitor your contributions and share them with the rest of the group as the discussion progresses. So first up, to take us through the policy brief is Dr. Navdeep Tangri, who is a nephrologist from the University of Manitoba in Canada and chair of GloPAKH's Medical Advisory Council. Nav, over to you.
Oh, thank you so much, Luanda. It's really a pleasure to be here and to introduce this policy brief on behalf of my group, which is the Medical Advisory Council. Just go to the next slide, please. So first, I want to outline that work on this brief is not coming from me. It's coming truly from this group. It was really a global effort and a collaborative effort in every sense. We had representation from Europe and Africa and Asia, from settings which have, and North America, of course, and we had settings which were resource limited, and we had settings which were resource rich. And so what this brief really represents is diversity in opinion and diversity in approach to tackling the epidemic of chronic kidney disease. Next slide. We want to start by emphasizing in the brief that chronic kidney disease is a global threat. The number that's seen almost everywhere is 850 million worldwide and more than 10% of the general population. But as many of you know, fewer than 10% of people living with CKD are aware of their disease, and in many countries, physicians don't code or diagnose CKD even when there's lab evidence. So in every sense, it's probably a billion-person disease. CKD leads to kidney failure. Just go back with this. CKD leads to kidney failure, which is catastrophic and can lead to dialysis and death. But it also leads to a disproportionate burden of cardiovascular disease and adverse cardiovascular health. In fact, there's millions of lives lost and days of disability lost due to cardiovascular disease from kidney disease. And finally, health inequalities or inequities exacerbate CKD. In the US, for example, Black Americans and other minorities have a higher burden of kidney failure, and globally, countries which are less which have less resources available to them, in those countries, kidney failure can often mean death. Next slide. This is a key point that we wanted to find. What is the need for screening? The need for screening is that people are generally unaware that if we don't screen, well, we won't find, because it's not that the symptoms are going to magically show up. This is a quote from Dr. Zhao, my colleague from China. It says nearly 80% of people are unaware that they have that disease. What are the symptoms? Well, the symptoms, as you will see, blur with a lot of common conditions. They're fatigue, nausea and vomiting occasionally, feeling of sadness, poor mobility, itching, dry skin, and heartburn, poor sleep. Many of us who have chronic diseases would say that you've experienced one of these symptoms or more of them at some time, but that doesn't mean we have advanced chronic kidney disease. So relying on symptoms alone is not enough, and that's why a comprehensive screening strategy for CKD is needed. Next slide. The second case for screening. So for screening to matter, not only you have to have a disease which you can catch early before symptoms, which is the case with chronic kidney disease. Second, you also have to have effective treatments available. So this is where there's really been a renaissance in chronic kidney disease management. And this is why it's worth talking about CKD screening in 2024, whereas it would not have been worthwhile talking about CKD screening in 2014. So let me walk you through those changes. First, once someone is diagnosed with chronic kidney disease, they can change their lifestyle. They can change their diet, they can exercise and maintain a healthy weight, and stop smoking. And this can help them manage their disease. Second, in 2014, we had one class of drugs that slowed the progression of kidney disease by 20%. These were renin-angiotensin-aldosterone, or RAS inhibitors. Now we have four classes of drugs. We have RAS inhibitors, SGLT2 inhibitors, MRAs, and GLP-1 receptor agonists. All of these drugs slow the progression of kidney disease by 20 to 40%, and their effect may be additive. So you have this scenario where presumably if a patient is at very high risk of progressing, they could be on four drugs and their risk of progression could be slowed down by 50, 60, 70, or 80%, really effectively postponing kidney failure forever. And this didn't exist in 2014, and this is why we talk about screening in 2024. In addition, just treatment for diabetes, high blood pressure, cardiovascular disease, and all the other things that come along with kidney disease has just gotten so much better. So I think we're making tremendous strides in the management of disease once we recognize. Next slide. So this group, as I mentioned, was quite diverse. So what we wanted to do was to look at two possible strategies to identify, screen, triage, and treat chronic kidney disease. The first we refer to as screening or population-based screening, which is the routine testing of everyone based on a broad criteria like an age of 50 or an age of 40. This is akin to colon cancer screening or breast cancer screening in many of these countries. The second was targeted screening. So targeted screening refers to not an entire population based on an age cutoff, but rather focused on people with diabetes or people with hypertension. And we felt that we had to consider both approaches because we live in a global world with different resources in different countries, and a one-size-fits-all is not the right way to do this. Next slide. So how do we screen? Well, we believe that there should be two tests done when you screen for chronic kidney disease, a blood and a urine. Now, it turns out the blood test is done quite often. Sometimes it's not followed up on. Sometimes it doesn't lead to a diagnosis, even when it should say so. But serum creatinine is often done, and that can help us calculate an eGFR or a glomerular filtration rate. But what's really missing? The key test for chronic kidney disease detection, particularly early disease detection, is the urine or the urine ACR. It doesn't require a blood poke. It can be done anywhere, and it can be done easily. We recommend urine albumin testing quantitatively, or we also recommend semi-quantitative methods when quantitative testing is not available. So this is really depending on the healthcare setting. We like to think of this as albumin A, B, C, D, and E. Albuminuria, blood pressure, cholesterol, diabetes, and eGFR. And intentionally, it's not just because it starts with A. Albuminuria is first. So we believe that albuminuria is the key marker. It's the key test to screen for chronic kidney disease, and it can help understand cardiovascular disease. So we're believers in screening with albuminuria. Next slide. So this is how do we make this happen in the countries that we live in and work in? First, I think it's important to leverage existing screening programs. So in many countries, colon cancer is the example I pick on because I'm actually actively trying to do this in my country. So it's in my country, in Canada, in Manitoba, Canada, where I work, there's colon cancer screening universally for everyone between the age of 50 to 74. Everyone gets an envelope at their door mailed to them to ask them to participate in colon cancer screening. So what I'd love to do is to get a urine ACR requisition sent to them at the same time. There's already an infrastructure. There's already an infrastructure for follow-up and diagnosis. And I think this is a great way to leverage an existing program. Second, I think we can leverage clinical laboratories for data that's already being collected and solve this problem where somebody has lab evidence of a disease, but it's not recorded in the electronic medical record. Now, the diagnosis of CKD is crystal clear based on the labs, but we don't just so see it reflected in the chart. So what we could do is look at central lab repositories from large lab providers like LabCorp, Quest, Life Labs in Canada, other large labs in other countries, and look to see people who have a diagnosis of CKD, particularly who have high-risk CKD, and alert the patient or the provider or both to the diagnosis. And thirdly, we could do employer-based screening. CKD is a major cause of disability, days of life lost, and years of life lost. We should encourage employers to include CKD screening with EGFR and albuminuria as part of their employer-run healthcare plans and their screening programs. So these are some of the ways that we thought of where very practically you could incorporate the insights from this brief into how you think about strategies for screening. Next slide. Other possible approaches could be a hub and spoke model. A hub and spoke model is successfully used in India, and my colleague Dr. Sahai, who's on this call, will be happy to speak to those. This really relies on dialysis centers as the hub and screening centers as the spoke. So patients and their families who come to dialysis, not the patients themselves who already have kidney failure, but their families, their friends, their relatives, can be screened for kidney disease when they come to the dialysis center. In addition, there could be lay workers going out into the spokes using community outreach programs and then connecting back with the central hub. The last thing I want to emphasize is sort of this holistic approach of cardiovascular, kidney, and metabolic health. The American Heart Association has really emphasized that we need to not just think of the heart or the kidney in isolation. We need to think of it as CKM. The heart is connected to the kidney is connected to the liver through metabolism. So all these diseases are connected. So let's bring it back to A, B, C, D, and E. And because I'm a kidney doctor, let's start with albuminuria. Next slide. So I think policymakers have an opportunity. The day is now, the time is now to treat CKD as a public health priority and ensure that at-risk people can access comprehensive screening and early treatment. We have the treatments available today. We have the diagnostic tests readily available. They're easy to do. They're not expensive. And they make a really compelling case to add on to existing screening programs. And I think if we do it and we do it right, we have a chance to remedy the chronic kidney disease crisis and tackle the dialysis epidemic head on. So with that, I'll hand over back to Luanda, who'll model the next part of the discussion.
Thank you, Nav. Insightful as always. I learn so much every time you speak at these fora. Just a reminder that if you want to read, well, we hope you want to read the policy brief, please visit our website, globalkidneyalliance.org. You'll have great access to the document, and we encourage you to engage with it meaningfully and share it with your colleagues. You can also email us at info@globalkidneyalliance.org to ask or request access to the policy brief. Want to take a moment here to see if we have any questions from our plenary. You would have sent your questions to us via the Q&A box. If you are still thinking about your questions, mulling over everything I've shared, that's okay. You can always send us your questions to the Q&A box during the course of the webinar. Okay, no questions yet. So we'll move over to our next session. So this is also a session of the webinar I was quite excited for. These are three speakers I have a lot of respect for and always learn so much from you all when you speak. We are going to welcome back to the virtual stage Navdeep and introduce his fellow panelists, Dr. Manisha Sahai, also a nephrologist at Osmania General Hospital and Medical College in India. She is a member of the GloPAKH Medical Advisory Council, so a colleague of Nav's in this respect. We also have Amanda Dehay, who is a patient advocate from Renalou and National Kidney Health organization in France. Let me kick off with you, Amanda. You are a mother to a son whom I know you love very much, who is living with CKD. Can you please share briefly your journey, sort of in this experience that you've had trying to support him as he's navigated the condition?
Sure. So my son was diagnosed with a rare kidney disease 3 years ago at 18 years old. He went from normal life to collapse at speed as he became symptomatic very late. In fact, by the time his diagnosis was confirmed, he was already in kidney failure. So then followed a frantic period of dietary restrictions in order to try and delay the initiation of dialysis. He became quite malnourished and went on to dialysis rapidly anyway. And the first form of dialysis he tried didn't work for him, so precious time was lost. And by the time he was put onto hemodialysis, he was in a terrible state. So the doses given were so strong. He had cerebral edemas, so brain swelling after sessions, which happened 3 times a week for 4 hours each. He felt terrible the day before, exhausted the day of, better the day after, and then bad again, just in time for the next session. My son managed to get his transplant within 7 months because I could be his living donor. Transplantation is the best kidney replacement therapy option in terms of quality and quantity of life. However, my son's transplant was rapid. Even in France, where these services amply exist, it can take twice the time it took for him, and sometimes far longer if patients are on the national waiting list, waiting for a deceased person's kidney. Basically, we all know it. Demand for kidneys massively outstrips supply, leaving too many people to suffer and sometimes die. And even once transplanted, the immunovulnerability and medication regimes are super complicated for my son to manage and live with. So you can imagine, as his mum, it's been fairly agonizing to watch. He was 18, so that to catch him in a screening program is complicated. But I think the main point is here that today drugs do exist to slow down the progression of the disease he has if it is detected in time.
Thank you so much, Amanda. Always feel so inspired hearing your story. You are here in your capacity as a mom to somebody with CKD, but also as a professional who has a vast amount of experience working in this space. Can you please share how the policy situation appears in France with respect to CKD screening, and also give us some ideas for how patient advocacy organizations can work alongside governments to shape better policies that can usher much needed screening services for at-risk CKD patients?
Sure. So perhaps the first point, in France, we currently have two major hurdles. I think they're fairly universal. But the first is that there are still too many people who are unaware of the crucial role kidneys play and the burden of CKD. And the second is that even if people are aware, there is this belief, as Nav said, that CKD cannot be effectively prevented because that was the case in the past. But it no longer is the case, yet this belief still sticks. So French health authorities have recommended CKD screening for any at-risk person of any age since 2023, but there's still progress to be made. Why? Partially because general practitioners who are on the front line for prescribing screening and treatments, they're struggling with resource shortages, which is again fairly universal. But that is precisely why these CKD detection and prevention measures are needed, right? Kidney replacement therapy, i.e. dialysis and transplantation, is the most expensive therapy per patient for the health insurance system in France. It outstrips cystic fibrosis and lung cancer, for example. So to accelerate the progress needed, the French health insurance body who pays for all this care has just issued its annual report on how to improve things. And for the first time, there's a major focus on CKD. And the government has announced a series of targeted measures. So, for example, it's going to target individual general practitioners to raise awareness about CKD and about these new treatments and about the screening options. And all these efforts and what the general practitioners then do will be captured through a series of indicators that general practitioners must follow for their at-risk patients. In terms of policy wins, it's early days, right? But it does look promising. And the last bit of your question, Luanda, what did Renault do in this as a patient advocacy organization? Well, I think played quite an important role in bringing this about, drawing on our community's experiences as a powerful basis for our advocacy messages. We back up what we say with data. Now, that's a critical point. We generate our own through a satellite organization, and we use kidney registers, and we collaborate with key opinion leaders, nephrologists, health economies, public health people to keep our messages evidence-based. We've built up relationships of trust with the health authorities over 20 years. And lastly, another key point, we go above being observational and we're propositional. We deliver clear, digestible propositions that we then collaborate on with health authorities and healthcare workers for change. Because we work this way, we are heard. We're a small organization, but we punch well above our weight by using that kind of methodology.
Thank you so much, Amanda. Now to shift focus slightly from France to India, I'd like to chat with you, Manisha, for a moment. The burden of CKD is particularly evident in low to middle income countries. As a nephrologist working in India, a country with a high prevalence of CKD and a large patient population to serve, I can only imagine how complex the challenges you face are there. So can you please characterize some of those challenges for us, especially as they pertain to making screening services available for at-risk CKD patients?
So thank you. It's an honor to be here. And I come from India, a low middle income country with a huge population, 1,400 million. So you can imagine, and the prevalence of CKD is around 17%. And we have 2 lakh people who need dialysis every year. Number of transplants is 15,000 per year. So you can imagine the huge burden. Now coming to screening. So high-risk group screening seems logical, more cost-effective. You can screen diabetics, hypertensives, elderly maybe. But the problem here is that we have a large pool of patients who are not diagnosed with diabetes or hypertension. They have the disease but have never been checked for it. So if we just employ the high-risk screening, we are going to miss them. Then in India, we have a unique disease called CKD of undetermined origin, where young people are affected, no symptoms at all. Urine output is good, no swelling, nothing. So unless you do the blood test, you won't be able to detect them. So if you do high-risk screening, you are going to miss half of the people. So I think in India, finally, you boil down to doing a population-based screening, and that should be the national policy. Now, coming to the screening tests, that's another challenge because creatinine is available. Many sites may not do it very accurately, but at least it costs $1 and can be done. Urine albumin creatinine ratio, which Dr. Tangri spoke about, is not available universally. Instead, we have the urine protein creatinine ratio. So that can be used. In addition, so these tests cost hardly $2, can be done at most of the centers. In addition, we have glomerulonephritis, which presents with hematuria. So if you do only these 2 tests, you may miss that. So in addition, it's better to do a urine examination as well. And Dr. Tangri very nicely said ABCD. That is very well applicable to India because when we are screening for CKD, only proteinuria and creatinine are not sufficient. We should look at the sugar level and blood pressure, because as I said, many people have never been tested. So ABCD algorithm is very good for India. Then next challenge is the doctor-patient ratio is terrible. Very few doctors. So we have to use the frontline workers. As I said, 1,400 million population to be screened, and we have 2,000 nephrologists to screen them. Definitely not possible. So we use the frontline workers and we need to train them. Many of them are not trained. We have primary care, secondary care, and tertiary care, and the screening should go on as an integrated part of daily care at all the levels by whosoever is employed there. Even a healthcare worker should do the job. Now, the thing is, what is the point of screening if we don't have the drugs available? So in India, good thing is we have a lot of low-cost generic drugs which are locally available. We have even SGLT2 inhibitors, RAS blockers. SGLT2 are available. Dapagliflozin is available at very low cost. So the drugs for treatment, they just amount to $5 per month. So which is quite eminently affordable apart from the lifestyle measures. So drugs are definitely there. Therefore, screening is definitely relevant. Now, is dialysis and transplant available in India? So the good point is it is available. We have a huge network of dialysis centers across India, and it is partly funded also for those people who are below the poverty line. But the sad part is a lot of our budget is going into supporting the renal replacement therapy, but we have no funding for screening. And this is where the policymakers need to get involved, and we should have clear-cut packages for screening. Now, dialysis, we have $300 US dollars for dialysis. Transplant is $3,000 US, and screening package would be less than $1 US. So it's definitely worth it, focusing our resources on screening as well. And it is the need of the hour because our economy cannot go on supporting the renal replacement therapy forever. We have to work on prevention. The other thing is about implementation. So there is no point in having a policy if it's not implemented. So we should have it in our national guidelines, and it should be made mandatory. The screening for protein, creatinine should be mandatory at all levels. Then the last point, last challenge is the awareness in the public is very poor. So this we can do by utilizing the patient support groups as well as public awareness programs. You would be happy to know that India successfully eradicated polio. And why did this happen? By roping in the celebrities. So one message by an actor in the films or on TV, check your kidneys. Just do a blood test, urine test, goes a long way. Otherwise, polio was a dreaded disease and we were not able to eradicate it till the public awareness about the disease increased. So that's one important thing. And patient advocacy groups, we have some of them in India as well. And as Amanda said, it would be a very good resource to deliver the punch to the policymakers. We get them on board as well. Now, we have a unique model in India, that is the hub and spoke model, which Dr. Navdeep did talk about. So as I said, we have a huge network of dialysis centers in every nook and corner of India. So where other medical facilities are not available, dialysis center is there. So as of now, we are using the dialysis centers for treatment, but the same centers with the same staff can be utilized for screening. We can begin the screening at that center also with the attendants who come with the patient, who are diabetics, who are hypertensives, already have kidney disease in the family. So this hub and spoke model is now being focused on in addition to population screening at all levels. And lastly, whether we do the screening or not do the screening, those programs run parallel, but we should start by advising lifestyle measures to all diabetics, hypertensives in general for everybody. It doesn't cost anything much because finally after screening and detecting CKD, we are again going to treat diabetes in a diabetic patient, hypertension in a hypertensive patient, and obesity, which is becoming a big problem in India. So I think these are the 7 challenges and the proposed solutions in a large country like ours. Screening is the way to go. Prevention is important. We can't focus on the cure anymore. Thank you.
Thank you, Manisha. I think you've done a fantastic job sort of summing up the comments that Nav shared, summing up what, Amanda shared, and demonstrating how even as we live in different countries, some of our challenges are similar and the solutions that we can employ are applicable in the various contexts where we are. We spoke of the need for routine screening and targeted screening where it applies. Now, can you please elaborate very briefly on why policymakers ought to prioritize screening measures that are applicable to their countries at a national level to achieve the things that Manisha and Amanda have spoken about?
Yeah, very briefly, I think healthcare is organized very differently in each country. In my country, healthcare is funded at a provincial level, not at a national level. But some guidance from the National Ministry of Health will be helpful. So if the National Ministry of Health says CKD screening is important, then we're likely to get the first one or two provinces to actually start doing it. And that's the momentum we need to kind of push this forward. So I think it's really got to come from top down, and then it'll come to the province, the state, or the city, or whoever funds healthcare in the jurisdiction to then actually do it. But we need an overarching view from the national level that this is a priority.
Wonderful. So we need to screen in ways that are applicable to our context, but we also have to get policymakers on board to fund screening and make sure that policies are implemented or adopted that can guide or provide guidelines for how screening programs should be rolled out nationally. So we've stressed enough the fact that CKD poses a growing threat with dire consequences to patients, caregivers, the economy, the environment. We know that we have an opportunity to slow down disease progression and prevent death by implementing treatment measures, but we can't do that unless we act early. That's why we have talked so much in the session about the need for screening strategies. We have to prioritize screening because if you don't know who has kidney disease, it's impossible for you to figure out how or when to start treating them. But like Manisha mentioned quite poignantly, we can't screen adequately if policymakers don't come to the party by providing us the much needed resources we need to make sure that people have access to screening, especially in contexts where the burden of CKD is huge. With that, I'd like to urge policymakers to engage meaningfully with the recommendations discussed here today, the recommendations outlined in our policy brief, and commit to taking the bold steps that we need to implement CKD screening strategies so we can realize better health outcomes. Also encourage our patient advocate community, our healthcare providers to engage in initiatives like these and the various other opportunities created by patient advocate groups in various parts of the world to raise policymaker awareness of CKD unmet needs and promote interventions like screening and various other policy-driven solutions. I want to drive us home by reminding you all to please visit our website, globalkidneyalliance.org, to download the brief. Please don't be shy, share it with all of your friends, your network, your colleagues, especially your friends in policy-making spaces. Please follow GloPAKH on Facebook, on X, and LinkedIn to stay engaged with our work. If you have any follow-up questions that we weren't able to answer or discuss on this webinar, please feel free to contact us on info@globalkidneyalliance.org. Our session has come to an end, but the work to mobilize policy champions who will take up this cause continues. And on that note, I'd like to thank our speakers and all of you for joining us on our webinar today. We look forward to connecting with you next time. Bye-bye.